Alrighty, hello everybody. So today I'm going to do your musculoskeletal review. I might have to split this video into two parts, just kind of a warning. I'm not 100% sure, and my goal is to try to get it all in this video, but I kind of forgot about how much content there is for this unit. Like, I literally have 5 documents for musculoskeletal because that's just how I am, but hopefully I can get it all in this video. I'm going to try to cover what I need to cover and go fast. So, sorry if there's like a bunch of background noise and whatnot. I'm house sitting and there's 3 dogs here, so they're bound to bark at some point, but okay. Anyway, so getting started. So this first document that I have, of course, they're going to start playing right now. This first document that I have is just on diagnostics and assessment for the musculoskeletal unit. So a lot of this is kind of just like basic A&P that you guys probably learned back taking your prereqs. So you probably know that there's 206 bones in the body. That's like the function of the skeletal system. Obviously, your skeletal system does so much for you. It supports surrounding tissues, protects your organs, manufactures blood cells, calcium and phosphorus are stored, and we also have bone marrow, which is obviously responsible for all your blood cells. So bottom line is the skeletal system is very, very important. Growth and metabolism. See, I feel like most of this is A&P, but I feel like Gretel. But I feel like understanding like the basics of this is going to help you guys with like the disease processes that we're going to cover. So when it comes to growth and metabolism of the skeletal system, so bone growth stops between like 18 and 25. It's usually a little bit sooner in girls and a little bit later in guys. That's just something that I've always remembered. So you have your epiphysis, I can never say it, your growth zone. So that, remember, is between your epiphysis, I think that's how you say that, and your metaphysis. And so that's like the area that actively produces bone and causes like longitudinal growth in children, can cause growth fractures. And I actually had a growth fracture when I was, I think I was 10 in my growth plate. If you guys have ever seen me in real life, I'm actually almost 6 foot, so very tall, but I grew very, very fast when I was a kid, and so like I grew so fast that my growth plate couldn't keep up and actually fractured. And so that is something that's really important because a lot of times in kids, so maybe not for like this exam, but like in peds, that's something that you guys see a lot if you're in pediatrics is growth plate fractures, because kids are constantly growing and things can happen. Bone marrow, I don't really remember there being any questions about like this kind of stuff, but like bone marrow, remember we have red and yellow bone marrow. So red marrow, that contains all of your hemopoietic cells, so like your red blood cells, white blood cells, platelets. Yellow marrow, remember, is like your fat in your cartilage. So one thing I would say that's probably really important to know is this little tidbit I'm about to tell you guys, and it's above 35, your bone reabsorption accelerates, so your loss of bone mass. And so this is what predisposes older adults to injury. And so this is why we're always concerned about older adults and like fall risks, because older adults just don't have the protection that like you and I might have. And so that's why like we're always worried about fall safety, always doing those home assessments to make sure that they're safe. And so another thing, it relates to how we have like estrogen. So like as you get older, you lose estrogen. Vitamin D and calcium are within the bone. So obviously if you don't have vitamin D and calcium, then you're going to have weak bones. PTH regulates the amount of calcium in the body, and that's the parathyroid hormone. And then testosterone stimulates bone function and formation as well. But so why I said that's important is because it'll kind of come into play when we talk about like osteoporosis and stuff here in a little bit. Joints. So just remember, like, your joints are points of articulation, provides movement and flexibility. And we classify joints on like the type of range of motion they allow. So remember, like, synovial joints are the ones that move really freely. I remember, oh my gosh, I just remember so explicitly studying joints in A&P. But I'm not going to go into any more of that because it's not on the exam. Supporting structures, you have muscle. So remember, you have a couple different types of muscle. You have cardiac, which is obviously around the heart, smooth muscle, which is in the walls of hollow structures, and then skeletal, tendons, cartilage, ligaments. Okay, yeah, that's like not, okay. Okay, so like all of that was essentially A&P review. You're not going to be tested on like the specific A&P, anything like that, because this isn't A&P, this is adult health too. But I think that it's just kind of important to understand like the basics of what the skeletal system is, how it functions, because it helps you to understand the disease processes that we're going to talk about. These dogs. Okay, so moving into assessment. So when it comes to skeletal system, obviously we're going to do the same thing that we do with any type of system, and we're going to take a really specific like H&P. So some specific things we want to look for that relate to this unit would be like family history of things like osteoarthritis, scoliosis, rheumatoid arthritis. Those are all things that can be genetic. Obesity, because if you think about it, if a patient is obese, it puts a lot of pressure on those joints, and so that can actually lead to arthritis. Also asking about exercise, because exercise obviously helps your bones to be nice and strong. So if you have a patient that's not exercising routinely, then you might make a note that like they're more prone to injury. That's also why, like, if you guys ever did sports, so I remember when I did basketball, that's why like strength training was so important, because a lot of times injuries with the skeletal system can happen because there's an imbalance of strength. So like if your right side is stronger than your left side, then like causing sudden movements can cause an injury. So that's why like with basketball and like really any sport, that's why strength training is so important, because you just kind of like, sorry, these dogs are just driving me insane. I'm tempted to put them outside. But that's why it's so important with skeletal system to assess your patients and see like how much they exercise. Other things to look for: do they have gout? Do they have parathyroid hormone issues? Ask about pain. Do they have pain with movement? Any stiffness? If they have pain in their bones, is it worse in the morning, worse at night? Does activity help? Infections. Could they have had an infection that entered a bone? Diet and medication. There are definitely some questions you're going to want to ask your patients. So you want to ask about steroid usage, because long-term steroid usage can weaken the bone. That's very important. You want to ask if they're on calcium or vitamin D supplements. That can help improve bone health, especially if they're not getting it in their diet. And then do they have a diet high in calcium or vitamin D? So like, do they intake dairy, dark leafy green vegetables, broccoli, almonds? I remember we talked a little bit about how like if you're vegan, sometimes vegans can have an issue with getting like calcium in their diet because they don't eat or don't consume dairy products. So that's definitely something to keep in mind with your patients. So once you get the subjective information, you're going to start going into your physical assessment. So we're going to look and inspect a patient. So, look at their posture. Do they have scoliosis? Do they use a cane? Any swelling, range of motion issues, deep tendon reflexes. And I have this highlighted, and I feel like we had a question on this at some point, but you always want to compare extremities when you're doing a musculoskeletal assessment, 100%, because you might have an abnormality on one side of the body with like a certain bone, but you could actually have that on the other side and it might be normal. So that's why, like, if you notice, I feel like we've had a question on this maybe on like NCLEX practice exams. I don't think it was on our exam specifically, but if you have, I know I've had this question on like NCLEX practice. So if you ever notice like an abnormality with one side of the body, I'm so sorry. The answer is always you want to inspect the other side first because you want to compare and see if that's like normal or not normal. Okay, Ollie. You're also going to look at neurovascular assessment. So you guys, I feel like I've mentioned the 5 Ps all the time. So remember pain, pulses, paresthesia, pallor, and paralysis. Okay. One other thing you can look at is the acronym DEPT, which is deformity, edema, pain, and throbbing. So you can look at this if they have any sort of issue in the skeletal system. So that is kind of like your assessment. Okay, so then moving on to some like specific diagnostic tests you can do for the skeletal system. So the first one I have is just like radiographic examinations. So we have a couple different things you can do. You can do an X-ray. We have myelogram. So this is very important. I remember we had a question on myelogram, and basically what you need to know is that, so this procedure is when IV contrast is injected into one area around a nerve root. And so basically you see how the bone is affecting the nerve. But what I remember you need to know for the exam is that a headache is a typical side effect with this, but you are still concerned if a patient reports a headache because there could be potential cerebral spinal fluid loss. The headache should resolve in 1 to 2 days with fluids, but even though this is a side effect that a lot of times we expect our patients to have with a myelogram, they should still report it because, like I said, it could result from cerebral spinal fluid loss, and that's obviously more serious. And so this is done in your spinal cavity. We also have an arthrogram, which is the same sort of thing. So it's when we have contrast injected into a joint. CT, MRI, bone biopsy, all those fun things. I'm going to come back to labs. So then other tests we have are like ultrasound. So arthroscopy is when we basically make like a really small incision. So this procedure is minimally invasive, and it's actually becoming very popular nowadays because of that. And so this is where you would like make a really, really small incision and you'd stick like a camera in, and so it internally visualizes joints. And so normally it's done in the knee, but like you can do it other places as well. So the things as a nurse, like nursing interventions that you guys should know is if you have a patient that has an arthroscopy, they can have ice on and off for 24 hours. They should elevate the extremity, watch for infection in the first 12 to 24 hours, and you should always be checking neurovascular status. Next thing is a DEXA, which is a dual energy X-ray I can't pronounce that, but this is used to estimate bone density in bones like the hip, and it uses minimal radiation. And so the thing you need to know about this is that we do this to help diagnose osteoporosis, but it's painless, there's no contrast, it's non-invasive, and claustrophobia shouldn't be an issue. And so it's really important that you guys know we recommend this at 50 for patients because that's when they start getting to that age where we're like, patient might have osteoporosis for our older women. There's also a bone scan, which uses dye through an IV to detect bone disorders. It's not as common because we now have MRIs. One thing I've highlighted from this is that we don't need radiation precautions, and we don't have to we don't need radiation precautions, and we do want to push fluids to help excrete the dye. There's also a thallium test. I really don't think I pronounced that right. I don't think I've ever pronounced that right since patho, but this is where we inject it in patient's lye for 30 to 60 minutes. And so basically we're having that pool in the bones, and then we check for cancer or other inflammatory conditions. One thing I feel like we had a question on this, maybe not, but you can inject 4 to 6 hours prior to the scan, and then you repeat the scan, and this is done in like 24 to 48 to 72 hour intervals. And then the other thing is your labs. This is very, very important. I know we had a question on, I'm pretty sure it was calcium. So know your normal labs as they relate to the skeletal system. So know that your calcium should be 8.6 to 10.2. Your phosphorus should be 2.4 to 4.4. Know that you have several serum muscle enzymes that you're going to look for. So CK, which is creatine kinase, is highest in skeletal muscle, and its increased concentration is associated with muscular dystrophy and trauma. So this is something that we're going to look for in our patients that we think have MD or have just sustained some sort of trauma. The normal ranges I have written down are 20 to 200 in men and 20 to 180 in women. These other ones I don't really remember being on the test, or I don't really remember them being important, but I'll mention them anyway. So we also have alkaline phosphate, which is produced by osteoblasts in the bone, and so this is needed for mineralization, and it's usually elevated with fractures, bone cancer, osteoporosis, Paget's disease, or osteomalacia. LDH is lactate dehydrogenase, and so this helps glycolysis to occur and will be elevated in muscle problems. C-reactor protein, this is used to diagnose inflammatory infections and widespread malignancy. And so this is present in large amounts 18 to 24 hours after the onset of tissue damage. I don't really remember those last three being anywhere on the exam, but I would definitely know your calcium phosphorase and your creatine kinase. So really with any of these procedures, I talked about some specific nursing interventions that you should keep in mind for a couple of them, but just some things to keep in mind for overall would be there's always going to be a pre-op checklist you should go through. You always want to ask, does your patient have IV access? Do they have consent? Patients should be signing that consent only after they've talked to the physician, and remember that as a nurse, we don't actually explain the benefits and whatnot for a procedure. That's up to the MD. That's why they have their doctorate. However, as a nurse, we're responsible for witnessing their signature. You also want to ask about allergies to dye or shellfish, because that can be a contraindication for any of these procedures, or for any of the procedures that use dye. And then you want to make sure that the correct site is marked. So that's kind of just skeletal system in a nutshell, just the overview of what it is, some diagnostic exams, just some things to keep in mind, your labs. But like I said, the A&P, you're not going to be tested directly on A&P because this isn't A&P. But nursing interventions and just kind of understanding that your A&P can help you to piece together, okay, if I'm the nurse, what am I going to do? So the next thing that I'm going to talk about are fractures. That's the other document that I have here. So fractures is a pretty common thing. It's a really big portion of the musculoskeletal system unit because, like I said, they're very common. There's lots of different kinds of fractures. I would definitely know these. I feel like we had a matching, and it was different pictures, and you had to match it with the right fracture type. So just know a complete fracture is a break in the bone that leaves 2+ fragments. Incomplete is a partial break, and so it leaves a deformed bone. A closed/simple fracture does not break through the skin, whereas open protrudes through the skin. A pathologic fracture is secondary to disease. Most of the time it's cancer. Fatigue and stress is a sudden force or prolonged stress. So this is seen in athletes. This was also when I talked about how I fractured my growth plate. That was because of prolonged stress from my growth. And then a compression fracture is usually in your spine, and it's from weakening of the vertebrae, osteoporosis, or because of a tumor. So your risk factors for a fracture would be osteoporosis, advanced age, Caucasians, certain drugs, and also women. Those are just kind of the categories we tend to see these in more. Assessment-wise, it's pretty much everything that we just talked about in the beginning of this video. So you're going to ask about pain, Can they feel the area? Your 5 Ps, check their skin temperature, cap refill. Can they move it? You should also ask about occupation and their nutrition, because that can tell you like how well the bone is going to heal and maybe even like how bad it was. You also want to get a history of what happened and the mode of injury. So trauma would be like a car accident, a horse accident, a fall, whereas bone disease would be like cancer, osteoporosis, malignant myeloma. One thing I have highlighted that I can't remember if we had a question on, we might have, but as I talked about, there's 5 Ps, but there is like a 6th one. So this is, I cannot, poikiloothermic. That would be like the 6th P, and that just means it's cold to touch because of the lack of circulation. Another thing relating to the 5 Ps is that partial or full loss of sensation is a late sign. Clinical manifestations, just think about if you've ever had a fracture. Chances are most of you guys have had a fracture of some sort, so you're probably going to have swelling, maybe even a shortening or rotation, loss of range of motion, pain, tender. You might have bleeding, ecchymosis, bruising, which is just like part of the natural and normal injury process. Look for a muscle spasm, crepitation. So this is really important. So crepitation is like that crackling and grating noise that you can hear with movement. So this increases your chances of having non-union. So that's very, very important to understand with patients with fractures, because you need to recognize it and understand that they might have a complicated recovery. So moving on to how we treat fractures. Biggest thing, immobilization. Also, I don't know, I'd probably mentioned this like way too many times, but I've been a tech on ortho for the last year. So really all of this musculoskeletal stuff is like second nature to me, and I'm more than willing to help explain any of it to you guys even further, because I do this every time that I work. And I've seen quite a few of these things. So immobilization is what we're going to do with the fracture in order to get it to heal. So we're going to do that with like a splint, a cast, brace, immobilizer, fixation. So important things to remember with this is that we always want to check circulation before and after splinting, because obviously we check it before, because if they already have some sort of circulatory issue, we don't want to put a cast on it, because that's just going to make it worse. And then we're always going to check it after, because we don't want it to be too tight and we don't want them to get like compartment syndrome. So circumferential immobilization. So this is when we encircle a limb. So it's just kind of a type of immobilization. So this would be like a cast, and it immobilizes above and below a joint, restricts movements, and allows for the fracture to heal. So some important things with cast. So we want to put pads over bony prominences. So like if you have a patient that gets their leg casted, sometimes they'll put a pad on the heel. So that way, like over time, you don't get an injury on the heel from the cast. If you have a plaster of Paris cast, you don't want to put direct pressure on the cast. It usually sets within 15 minutes, and you don't want to bear weight for 24 to 72 hours. And it's synthetic, so it's a lot lighter. Nursing interventions for if you have a cast, very, very important. You guys need to know this. There's a section in your textbook that has all of these and more. I forget what page it's on, but you definitely need to like know this, because I remember we had a select all that apply, and then we also had like just other questions about it. So some nursing interventions for cast that you want to teach your patients is don't stick anything down the cast. They should use their palms to like itch the area. You can apply ice to the surface, especially for the first 24 hours, but you don't want to get the cast wet. So you want to use like a plastic bag or cloth. Check with the healthcare provider before you tell a patient it's okay to get their cast wet. You would dry it by blotting a towel or a hairdryer on a low setting, because you want to keep the cast dry. Don't ever remove the padding. Don't bear weight for the first 24 to 48 hours, and you should always elevate a cast for 48 hours. Move the joints around regularly so you don't get contractures. If you have itching, use a hairdryer on a cool setting. Don't cover with plastic for long periods of time. However, you can use plastic for if patients think that they're going to get their cast wet. Just check with the provider first. And then you should always teach your patients to report signs of infection like smelling, increased pain, discolored toes, burning, tingling, and then just know that a complication of a fracture is non-union. One thing that we're going to talk about with bones really quickly and fractures is that if you ever have a patient that comes in, so they have an exposed bone, or you're with somebody and they have a fracture and they have an exposed bone, you always want to put a sterile moist bandage over it to help it. Splint it if you can, go to the ER, and you don't want to move it if there's a pulse, and the reason that you don't do that is because if you have a pulse, that means that like nothing circulatory is being affected. However, if you were to move it, then that could potentially like complicate things and could cut off the circulation. So that's why we don't move patients if they have a pulse. So there's a couple different things we're going to talk about here next. So one thing as far as treatment goes for fractures is we have closed reduction. So closed reduction is a non-surgical manual realignment of bone pieces, and this is very, very painful. So this is going to be like traction. Like I said, work on ortho, so I've had traction patients. It's definitely not very common, but like I get them here and there. I actually had a traction patient yesterday when I worked. A lot of times traction is used if you have patients that like have a really, really bad fracture that has to be fixed with surgery and they present to the ER because it's like a short-term resolution. We also might use it for the hip. That's just like one thing. But like traction, like I said, it's very, very painful. If you guys have ever seen traction, you know, but like if you haven't, look up a picture and you'll realize how painful that looks. But as far as traction goes and what you need to know for the exam, I would definitely just know the reasons that we use traction and then your nursing interventions. So if you haven't ever seen traction, I would recommend looking up a picture because it just kind of helps you understand these interventions. But basically it's like this like fixation on the bone, and then it goes through like a pulley system, and there's weights, and there's a certain amount of weights on the pulley system that helps to keep like the bone in correct alignment. And so like I said, we use Bucks traction for the hip, and it's like a big boot, and then we oftentimes use traction for the femur. And so it's just that application of a pulling force to provide reduction, alignment, and rest. The reasons that I have highlighted as to why we use traction is it decreases muscle spasm risk, prevents or corrects deformity and tissue damage, immobilizes, reduces fractures, promotes activity or passive exercise, expands joint spaces before surgeries. So I would definitely know those. I know we had to select all that apply. We can also use skin traction, which is kind of a similar idea. It's just with like tape or like splints, and we use that for short term until we can use that skeletal traction with like the weight system. Nursing interventions, definitely need to know these. So the weights should be hanging freely. Never, ever, ever should the weights be touching the floor. They should not be hitting the bed frame, should not be like moving back and forth, and we never, ever, ever want to remove the weights without an order. The only time that I've ever had a patient in traction that I've ever seen the weights removed is with a patient who had traction actually from her head. So she was in a halo and then had traction on the halo as well. And we would remove the weights when we would transfer her from the bed to the chair, because we could do that since it was like upper body. A lot of times when you have patients that have lower body traction, so like the hip or the femur, you're not going to move them. But bottom line is we don't move them and we don't remove the weights unless we have an order. You will do the x-ray with traction in place. We always want to be assessing the 5 Ps, assess neurovascular status. And the biggest thing is we always want to assess the skin at least every 8 hours and be careful when turning. We also want to make sure that we're doing pin care. So like cleaning around the area with chlorhexidine. And we want to be monitoring for complications like skin breakdown, soft tissue injury, impaired circulation, inadequate alignment, infection, and osteomyelitis. Next thing is we have external fixation. So this is often used to salvage an extremity that's at risk for amputation. There's a lot of soft tissue involvement and the pin goes directly into the bone, and so that's a huge infection risk and can lead to osteomyelitis. Like with the traction, we just want to make sure that we're performing meticulous pin care with chlorhexidine and that we're keeping that nice and clean. There's also open reduction and internal fixation, which is ORF, and that's a surgical incision to correct bone alignment. Yeah. So those are how we treat fractures. Your stages of healing with a fracture, there's a couple. So we have a fracture hematoma, which is first, and that's immediately after the fracture when there's bleeding or edema, and it can last up to 72 hours, and so we might see a bruise. Then you have granulation tissue, then callus formation. The 4th stage is ossification, which is 2 to 3 weeks after a break, and that's when a permanent callus of woven bone forms. And this is what impacts how quickly ambulation will occur. Then you have consolidation, which is when the distance between bone fragments starts to decrease, and then remodeling is when union is complete. Factors that affect fracture healing, age. So like if you're older, you might have more brittle bones, poor immune system. Infants can take 3 weeks for a fracture to heal, whereas adults can take 20. How displaced the fracture is, the site, the blood supply, how immobilized it is, are there implants, any infection, that sort of thing. As for pharmacological treatment, things that we would use would obviously be pain medications. We're going to check see if a patient has had their tetanus vaccine, and we might give antibiotics such as like cephalosporin if we think there's an infection risk or like before surgery just for prophylaxis. We're also going to give them muscle relaxants, so like Flexerol or Soma. These, you want to make sure that you're educating your patients though, because they can cause drowsiness, dry mouth, and fatigue, and so we don't want them driving. So that's fractures. I am now going to move into complications of fractures. First thing I have that I think I mentioned at one point is compartment syndrome. So compartment syndrome is when you have a decreased compartment size from some sort of pressure to the area. So that could be traction, damage, edema, bleeding, dressing, whatever. And so there's pressure on these nerve endings within a compartment, and that reduces blood flow to the area. It's usually in the leg that this happens, but there's 38 compartments throughout the body, so it could happen anywhere. The thing that sets this apart, and you need to know this as for a clinical manifestation, is it's going to be increased pain that is unrelieved. So these are going to be your patients that you're going to give all of their meds, going to give them their first, second, third line of pain relief, and they're just not going to get anywhere. You're also going to have those 5 Ps, and so they might have no pulse, like dorsalis pedis pulse. They might have a blue foot, might have numbness, tingling, that sort of thing. As far as your nursing interventions go, early assessment is the huge thing to catch for compartment syndrome. And so that's why we always check pulses before and after we apply a wrap or something. You don't want to elevate the extremity if they have compartment syndrome, and you also don't want to apply cold because that's going to cause further vasoconstriction, so it's not going to help provide blood to the area. Complications of compartment syndrome would be kidney damage, so know your signs of AKI, like looking for dark brown urine. And the only way to fix this is going to be removing that, like whatever's causing the pressure, and then also a fasciotomy, which is like opening the fascia and like relieving the pressure. Next, the second complication of fractures is shock. So bone is vascular, so if you have a fracture, anything, there's going to be a large amount of blood volume that's lost, and so that can lead to shock. And so like the femur, for instance, if you have a femur fracture, you can lose like a liter of blood. So know your signs and symptoms of shock, so like increased heart rate and decreased BP. And so for treatment, you're going to do fluid and blood replacement as needed. So then the third complication that I have here is a fat embolism. So this is a very serious complication in which a fat globule is released from the bone marrow, enters the bloodstream, and can lodge somewhere. It's usually due to a long bone fracture or multiple fractures, and is usually seen with like a crash injury. Diagnostic wise, we're going to look for a chest x-ray. Signs and symptoms are very, very quick, and so they're usually 24 to 48 hours after injury. And so you're going to look for like dyspnea, respiratory distress, decreased O2, increased respiratory rate. Cyanosis is a late sign, and then also just like sudden chest pain, sudden changes in LOC, increased heart rate. And so your treatment is always going to be directed at prevention. So that's why we do like turn, cough, and deep breathe, careful immobilization, supportive care, turning. But if for some reason a patient develops this, we're going to do supportive care. So like fluid loss, we're going to replace. If they become acidotic, we want to treat that, give them oxygen, and we might even need to intubate them. Next thing is a venous thromboembolism, so a DVT or a PE, which you guys have probably heard about so much by now. This is very important to know because this is the most common complication of a lower extremity surgery or trauma. We do lots of things to prevent this, so like anticoagulants, so I would know your anticoagulants that we sometimes use, like Lovenox. We also use compression devices like TED hose, sequential stockings. SCDs are the machines that we use on the ortho unit. We do early ambulation, range of motion exercises, things to just try to keep the blood flow moving. Another complication that we have is infection, and so this is because the body's defense is interrupted, and so your body is trying so hard to repair this bone that it can let down its guard and we can get an infection. This can also happen because if you have an open fracture or like a soft tissue injury, then it allows the outside world to go to the inside world. And so our treatment is aimed at prevention, debridement, surgery, and IV antibiotics for 3 to 7 days. So those are all complications of fractures. There's also some complications of healing fractures. I would know these. I think we had to select all that applies on these as well. So you can have delayed union, which is the most common, and that's when healing of a bone takes longer than expected. We have non-union, in which it doesn't heal at all. Malunion is when it heals in the right time, but it's unsatisfactory in terms of the position. Angulation is when it heals in an abnormal position in relation to the midline, and then pseudoarthrosis is a type of non-union in which a false joint is formed with abnormal movement. I also have some notes on a couple of like individual types of fractures. So we have hip fractures. Really the biggest reason that people are going to get a hip fracture is falls. It's really hard to fracture your hip because your hip joint is a very stable joint. So falls are like the most common in older adults. So this is where all of that fall risk material that you guys have talked about so much is going to come into play. So that's going to be no throw rugs, make sure your patients have good shoes, be careful with any medications that can cause orthostatic hypotension, change positions slowly, eliminate multi-level homes, that sort of thing. Risk factors, like I said, increased age, female, osteoporosis, and then the presence of a chronic condition. So your clinical manifestations are going to be an externally rotated or adducted hip, shortening of the leg, pain, that sort of thing. So our treatment, remember I said Bucks traction can be used. That's like the big boot. And so we tend to use this for 24 to 48 hours before surgery. And then we'll do like put pins or something in place. We can also do a hip replacement, and they might even need a prosthetic. You 100% need to know your hip replacement nursing intervention. So this is where we're going to use the abductor pillow, which it's basically, so like on my ortho floor, it's either pink or blue, and it's basically this pillow that we put between patients' legs because we want to keep them in an abducted position. We don't want them to cross their legs. We don't want them to bend to tie their shoes. And we want to force the hips to be greater than 90 degrees. And so that's why we keep that abduction pillow. We want an elevated toilet seat to help them remain neutral as well. So those are all things you need to know. You will definitely have a question on that. And it's abduction, like AB. Other things as a nurse that you need to do with hip fractures is to, like I said, maintain that abduction, change positions every 2 hours, turn, cough, deep breathe, range of motion, prevent DVTs, monitor for signs and symptoms of any of those complications that we talked about. Know that with your older adults, they have a decreased tolerance to medications, so we always want to watch for over sedation. They also should have a decreased IV rate because they have a congestive heart failure risk. They also have an increased risk for respiratory depression and delirium. We want to use side rails to prevent falls in the hospital, and they're also more prone to skin breakdown, DVTs, really any of those complications. The next fracture I have is a pelvic fracture. Really all you need to know here is that a pelvic fracture has a high mortality rate, and it's because you can lose 2 to 3 liters of blood with this. And so pain is the big symptom, distended abdomen, no bowel sounds, that sort of thing. Femur fracture, we've already talked a lot about femur fracture because that's really like the most common one that traction is used for. But it's usually due to trauma, and remember, you can lose like 1 to 2 liters of blood. A compression fracture is in your spine, so that's associated with decreased bone mass or osteoporosis. And then just overall kind of like summary for fractures is understand some nursing interventions. So remember, we're always looking at ABCs. We want to make sure that we visualize the area of concern to assess. Immobilization and splinting is how we're going to treat these fractures, and we're also going to potentially use non-surgical interventions first or until we can get surgery. Nutrition-wise, you want to encourage your patients to intake like calcium, vitamin D, to help strong bones, but also like protein to help with healing. We want to monitor INO, keep patient on their back if they have like an anterior approach. We're concerned about blood loss, pain control, the 5 Ps in neurovascular assessment, incision assessment, and elimination. Really all of your typical like post-op things. Okay, so that is everything for fractures. So next I am going to do immune disorders. So these are immune disorders that relate to the musculoskeletal system. Hold on, I'm gonna look at my notes here. Okay, yeah. So I think what I'm going to do, because I'm already at 45 minutes on this, and I still have 3 more documents to go through. So I think I'm going to do immune disorders on this one, and then I'll do a separate video tomorrow going over like going over musculoskeletal injuries, so like strains, sprains, dislocation, like carpal tunnel, that sort of thing. And then I will do, what is the other one I still have left? Oh, osteoarthritis versus rheumatoid arthritis. That way you guys aren't having to watch like a 2-hour long video because nobody wants to do that. Okay, so going into immune disorders, so we have fibromyalgia is the first one. So fibromyalgia is not very well understood, but it's basically a chronic problem of widespread musculoskeletal pain and fatigue. Usually there's multiple tender spots, but like I said, not very well understood. Your risk factors are females aged 30 to 50, sleep disorder, or if you have a history of rheumatic disorders, Lyme disease, things like that. So the 3 things that I have highlighted for clinical manifestations are fatigue, difficulty sleeping, and numbness and tingling of extremities. Other things you might have are like vision changes, headache, tender points. So you might have like trouble with vision, jaw pain, pain in your muscles, urinary problems, menstrual issues in women. One thing I also have highlighted is that depression is a major comorbid condition with fibromyalgia. So nursing intervention-wise, we're going to focus on pain, mobility, and fatigue and supporting those because, like I said, fatigue is like the biggest I guess like clinical manifestation and like difficulty sleeping, along with that pain, numbness, and tingling. And we're also going to provide emotional support. So there's actually fibromyalgia support groups, which I think is kind of cool. And then there's also alternative therapies like acupuncture and stress management that we can help give patients. Good hygiene is really important for these patients, along with sleep management. So you're going to want to teach your patients to avoid caffeine and alcohol in the evening and to not use their phone at night or first thing in the morning. There's also a couple medications that we can give them. So we can give them Lyrica, which is an anticonvulsant. We can give them duloxetine. One thing that's really important with these 2 medications is that they decrease nerve pain. That's why we give them, but you don't want to drink alcohol on them because it can cause drowsiness. We can also give them tricyclic antidepressants that helps with pain and helps to improve sleep. So like amitriptyline is one, for example. But it's important because these medications can cause orthostatic hypotension. Trazodone is also a med of choice for older adults for this condition because it has less side effects. And then we can also give patients NSAIDs, but should not be used with kidney issues or taken on an empty stomach. Next, I have scleroderma. So that's a condition where we have a hardening of the derma, so a hardening of the skin, and it's due to high ANA levels. Clinical manifestations are hardening and thickening of the skin, widespread vascular dysfunction, and fibrosis, and this can happen to any organ. I remember Dr. Schneider stressing that, and I think it was on the exam, but scleroderma can happen anywhere. So we can actually have it with our lungs, for instance, and so that can cause respiratory failure and is obviously very, 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 like life-threatening, I guess is what I'm trying to say. We can also have puffy, swollen, and non-pitting edema, shininess, that's like the sclerosis of the skin, and that shininess can cause ischemia and lack of blood flow and causes painful distal ulcerations, and we might also need amputations for these patients. Your nursing interventions are you always want to check renal function to check to see if they have sclerosis of the kidneys, along with checking that respiratory system for any sclerosis of the lungs. Immunosuppressant therapy, we can try this to slow the disease progression, but it doesn't have as much, doesn't usually like help as much. We also want to monitor for the cardiac, pulmonary, and renal disease, and death is usually caused by systemic disease with this condition. So if it gets to the lungs or it gets to the kidneys, that sort of thing. Next, I have Raynaud's phenomena, which you guys probably remember from health assessment, but this is when there's an interruption of blood flow, and so we can have white, purple, or like blue tips of the fingers. It can be primary and just like on its own, or it can be secondary due to another autoimmune disorder like scleroderma. Nursing interventions, we want to teach smoking cessation. A lot of times you're going to see this in your patients that smoke because smoking causes vasoconstriction. We want to protect extremities from the cold, so encourage them to wear like gloves and mittens in the winter. And we can also use calcium channel blockers to relax the vessels and not have spasms. So your calcium channel blockers are going to end in pine, so like amlodipine or otherwise known as Norvsec. Next, I have lupus. So lupus tends to occur in African American, Asian, or Native American individuals and is more common in females aged 20 to 40. There's a couple different types. So you can have discoid, which only affects the skin, or you can have systemic, which can cause like organ failure and can happen literally anywhere. Lupus is hard to diagnose because you have really broad symptoms, and a lot of times like it might point to something else. So things you're going to look for are an increased ESR. I forget what that stands, like erythrocyte sedation rate or something like that. You might have hematuria or proteinuria. Your GFR might be altered if it's in the kidneys. Clinical manifestations. So skin symptoms are going to be like, okay, basically your symptoms of lupus depends on where it's at. So you might have like general symptoms like fever, weight loss, or fatigue, but generally speaking, you're going to have symptoms with the system that it affects the most. So if it's in the skin, you have that butterfly rash. That's like the biggest thing. You're going to be photosensitive, so you're going to be sensitive to light. And then you might also get a rash if you're like out in the sun too long. If it's in the lungs, you're going to be tachypnic, might have a cough and pleural inflammation. And then if it's in like the musculoskeletal system itself, then this is where you might have arthritis. If it's in the cardiovascular system, this is where we might see pericarditis, vascular inflammation, or Raynaud's even. And then, like I said, if it's in the renal system, you might have hematuria or proteinuria. Complications, biggest complication, I know we had a question on this, is kidney function. So if you have a question that's like, you have a patient with lupus, which of these is the biggest concern? And they give you like an abnormal like bun, or I guess an abnormal creatinine, like that's the biggest thing you're worried about because Raynaud's can cause like AKI or kidney failure. You're also at an infection and cancer risk with any of these that you have immunosuppressants. As far as nursing interventions go, we are going to prevent organ failure. That is the biggest thing that you want to keep in mind, and your goal is disease management. So you want to teach your patients to stay out of the sun. They might use NSAIDs or hydroxychloroquine, prednisone, but just remember that if you use a steroid chronically, it can lead to hyperglycemia and osteoporosis. So that's very important. I know we had a question on that on one of the exams. I don't know which one, but chronic steroids can cause high blood sugars and then osteoporosis. And you also want to follow routine health maintenance, get vaccines when they're available. They usually can't take live vaccines due to the immunosuppressant therapy, but like these are patients that you want to encourage them to get like the flu vaccine. I would think now with like COVID times, these are patients that you would want to like have them get the COVID vaccine because anything that alters their immune system is going to make their disease presentation worse. I just know like the biggest thing with that is like the butterfly rash, and then like knowing that it can basically like cause your kidneys to go pretty south. So then the last one I have for immune disorders is gout. And so this is where we have high uric acid levels in the blood. And so it forms crystals in the joints. This is oftentimes genetic. Hypertension, diabetes, heart disease, those are all risk factors. Immunosuppressants. Usually it's in men until you get to age 60. After 60 is when we start seeing this more in female patients, and that's because usually estrogen protects women up until they're about 60 from developing gout. If you're obese or have gastric bypass surgery, you're also at risk. And then this is very important. If you eat high purine foods, so like red meat, shellfish, more than 2 beers a day, or you have soda pretty frequently because of the fructose, that can cause gout as well. That's very important. That's important because you want to educate your patients on avoiding those foods if they develop gout. As far as diagnostics, we're going to draw from either the blood or joint fluid and look at uric acid levels. It's usually in the low joints, so the big toe is the biggest one. And your clinical manifestations, it can result in unrelieved pain, redness, swelling, or obvious deformity of the joint. And so, it's pretty obvious. Nursing interventions, we want to teach these patients to maintain a healthy weight and diet. So, like I said, we're going to teach them to, have no more than 2 beers a day, monitor their red meat and their purine consumption. We want to start uric acid lowering agents, so we can use colchicine and allopurinol. So colchicine is used for an acute gout attack, and then allopurinol is a daily med that we use for chronic gout attacks. Chronic gout. So that's very important. I know we had a question on that, and I've actually had questions on that with studying for the NCLEX as well. So know that colchicine is for acute gout attacks, and allopurinol is like a daily med that you take for chronic reasons. We also want to teach them to put ice on the affected joint, elevate the area. They might use steroids or other NSAIDs for pain control and inflammation. Like I said, decrease alcohol, and just watch out for infection or other injuries. So that is everything on immune disorders. I feel like there wasn't too much on the exam from immune disorders. I would definitely know just a couple of things about each of those disease processes and just have kind of a general understanding of them and the complications, signs and symptoms, that sort of thing. Oh, one thing I forgot about gout, speaking of kidneys and complications. So I mentioned with how with lupus, the biggest complication is kidney function and kidney failure. This is the same thing with gout. So with gout, if it's untreated, those crystals, the uric acid crystals that deposit themselves in the joints, can actually deposit themselves in the kidneys and cause kidney stones. And that's actually one type of kidney stone, is that uric acid kidney stone. We can also form kidney failure, so CKD. You can also form diabetes and hypertension from chronic gout. And so those are all things that you want to monitor for. But definitely, I would say the biggest complication is forming kidney stones. Okay, so we are at an hour. So yeah, I am not going to do the rest of this review, but I will definitely do it tomorrow and get it up for you guys. So that's just musculoskeletal injuries, and then OA versus RA. Shouldn't take too long. It probably won't take an hour. But like I said, if you guys have any questions, please reach out to me, because a lot of this stuff is second nature because I see it all the time at work. But otherwise, I feel for most of my peers, this was definitely a pretty easy exam. It wasn't the easiest, but I would say that most of my friends got A's and B's. Like I said, this was my best exam. I think I only missed one, but I think a large part of that is because of my experience as an ortho tech. So more than willing to help you guys, but just stay strong, keep studying. The light is at the end of the tunnel. You guys can do it. And just know that I'm here for you guys. And if you have any questions, feel free to reach out, and I will talk to you guys tomorrow.